support transformation of their mental health services to ensure quality and promote human rights. WHO is about to launch a guidance and technical packages on the community mental health services, promoting person-centered and right-based approaches, about which we are going to hear more today. Michelle, welcome. The floor is yours.
Thank you very much. I'm just checking I'm unmuted, yes. So thank you very much for that kind introduction. And of course, the invitation to speak in this event. I'd just like to say that I've been incredibly impressed with the work of Mental Health Europe over the years, and really see you as a driving force for some of the change happening in mental health in Europe. And just congratulations for all your efforts and the impact that you're having. In my remarks, I'd first like to take the opportunity to introduce the WHO's Quality Rights Initiative, because this initiative basically provides a framework for our rights-based work in the area of mental health. And then I'm going to describe our most recent area of work around the guidance, which you mentioned, on person-centered and rights-based community mental health services, which we will be officially launching in 4 weeks' time. But first, to start with the Quality Rights Initiative, essentially Quality Rights is a global initiative to improve the quality of care in mental health and to promote the rights of people with mental health conditions and psychosocial disabilities. With Quality Rights, we work in several different areas. So one of the key areas is around building capacity of different stakeholders to combat stigma and discrimination, and to implement a human rights-based approach aligned with the Convention on the Rights of Persons with Disabilities. A second key area of work is to support countries to develop community-based mental health services and supports that truly respect human rights and a person-centered recovery approach. Thirdly, Quality Rights is working with and in support of civil society to empower people with lived experience and others to conduct advocacy, specifically to integrate a human rights-based approach and to influence policymaking in this direction. And fourthly, Quality Rights is supporting governments to reform policy and law in line with the CRPD and other international human rights standards. So through Quality Rights, we've already developed several capacity building tools, including an e-training program, which has equipped thousands of people across many countries in Europe, Africa, and Asia with the knowledge and the skills to implement human rights-based approaches in mental health on the ground. And stakeholders who have undertaken this training include mental health and health practitioners, people with lived experience, policymakers, NGOs and OPDs, academia and training, colleges, as well as school teachers and secondary school students. Currently, we have around 28,000 people who've signed up and are doing the course, and over 14,000 people who have successfully completed the course and received their WHO certificate. So that's a huge achievement already. But, you know, although extremely important, capacity building on its own is not sufficient in and of itself to completely transform the mental health system. And for that, fundamental changes are required to the mental health service paradigm, including a change away from the deeply entrenched reliance on the biomedical model and the use of coercive practices towards a human rights-based paradigm or approach that does not use coercion. And this is an area where there's been far too little work. However, I'm really pleased to announce that on 10th of June, we will be officially launching WHO's new guidance for countries on how to put in place person-centered and rights-based community mental health services. And this guidance is the first of its kind and has been many years in the making. It's involved months of intensive research, many months, not just months, some years of intensive research, and many rounds of in-depth consultations with all key stakeholder groups and experts in countries throughout the world. Within this guidance, we highlight good practice services from different regions that align with the key CRPD criteria, including respect for legal capacity, non-coercive practices, participation, and community inclusion. The guidance also provides detailed information on how each of the services showcase explicitly implements these key CRPD criteria in the setup and running of the service. What's become clear is that none of the services is perfect, but these examples provide inspiration and hope as they've taken positive, concrete steps to align with the CRPD. And they've managed to do so in spite of the fact that they exist within policy and legal contexts that are not aligned with the CRPD. So it's even more impressive to think that these services have achieved so much in the face of so many barriers and challenges. The ultimate aim of this new WHO guidance is to show policymakers, service providers, and other key actors that good practice, rights-based services exist. They are possible, they make a real and positive difference in people's lives, and that action needs to be taken to invest and scale up rights compliance services, such as the ones that we showcase. So just a few words about how the guidance is organized. There's an overall document which sets the context, summarizes the good practices, and makes specific recommendations for integrating these approaches in health and social sectors. And then we also have 7 supporting technical packages, which contains even more detailed information on the good practice services, the challenges that the services faced and what they did to overcome the challenges as the service evolved. And in each technical package, we also present a series of action steps to help others set up a similar service in their country. Each of the technical packages focuses on a specific category of mental health service. So there's a package on crisis services, another on outreach services, on peer support services, supported living, community mental health services. And there's also an important package which brings the different services together, and it's really focused on establishing comprehensive networks of services that interface with the social sector. So now that this huge piece of work has been completed, the next phase in our work is to provide countries with very clear and detailed guidance on how they can reform their legal and policy frameworks so that they too align with the international human rights standards, in particular the CRPD. And this is going to be extremely important in complementing the work that we've done to date and to produce the long-term sustainable change that's needed to make sure that all elements in the mental health systems are rights-based and aligned to end, the coercive practices that we see, to make sure that legal capacity is protected and respected, and to promote community inclusion and participation. So I would like to conclude by saying that WHO looks forward to working over the next months and years with a growing group of stakeholders who are committed and engaged to seeing mental health systems and services reformed all over the world to better meet the needs of people with mental health conditions and psychosocial disabilities, and of course to ensure that their human rights are respected and promoted. Thank you very much.
Thank you, Michelle, for this wonderful presentation and indeed very important work you do. I have noticed that Madam Commissioner is back with us. Madam Commissioner, are you there?
Can you hear me now?
Yes, we can. I propose that...
I have some problems with my laptop because it says that you removed me, so the host removed me, but anyway, I'll try now from my phone. So if you do not hear me or anything, just give me a sign.
Okay.
Yeah, I'm terribly sorry about this, but at least I could listen to Michelle now, and it's important. You know, I heard some important things. So I was saying about something that was already raised by many of you, and it is related to the evidence of devastating impact of the COVID-19 pandemic on mental health. The death of loved ones, of illness, loss of income, also isolation and disruption of our daily routines has taken an incredibly heavy toll on our mental health. But the pandemic has also been affecting the delivery of mental health services themselves. We know that pandemic affected certain demographics, such as children, older persons, women, and already marginalized groups in a disproportionate manner. And mental health, unfortunately, is not exception. As services are slowly being resumed and there is a movement towards normality, it is still unclear what the lasting impact of this situation will be in the existing mental health services, for example, as a result of the increased use of digital services. At the same time, I would say that the pandemic exposed as never before the many failings of non-human rights compliant mental health systems, a situation that organizations like Mental Health Europe and bodies and institutions like my office have been denouncing for years. Institutionalization, coercion, stigmatization, and disempowerment have for far too long been defining features of these systems, despite the countless human rights violations documented in psychiatric hospitals by bodies such as the European Committee for the Prevention of Torture, the CPT, and the prevailing illusion. The prevailing illusion has been that these violations were the result of individual circumstances or the conditions in a particular hospital. This, however, overlooks the fact that an institution and a coercion-based mental health system naturally tend to gravitate towards these human rights violations, making them easier to commit and more difficult to detect, notably because of the power asymmetry it creates between the patient and other actors in the system. The pandemic gives us a unique opportunity, I would say, to engage with states and the general public in order to explain why this must change and why we cannot go back to business as usual any longer. For example, we need to build on the increased awareness of how institutions violate the human rights of anyone placed in them, including, but not only, persons with psychosocial disabilities. We also have witnessed the crucial importance of increasing the capacity for early psychosocial interventions through innovative and community-based services in order to prevent future burdens on mental health systems. This is a good time to challenge centuries-old assumptions, stigmas, stereotypes regarding mental health. It is good time to imagine and lay the groundwork for a better future. And the title of this discussion could not have been better chosen. But we still have a lot of awareness-raising work ahead of us, even in those countries which have begun to accept the need to transform their mental health services by reducing recourse to institutionalization and coercion. Unfortunately, my experience is that for policymakers in certain member states, community-based services are often still institutions located in less remote locations. We need to make sure that the necessary shift from a biomedical to psychosocial approach to mental health is accompanied by throughout reevaluation of what really a community actually means. Thanks to the work of Mental Health Europe and others, we now know more about encouraging examples, good examples emerging from around Europe and beyond as to what truly person-centric, recovery-oriented mental health services could look like. A common feature in this example is that they engage the community in the widest sense, including the physical community, family, neighbors, colleagues, and others, while promoting at the same time inclusion and countering stigma, which is quite a complex issue, but it is the way to follow. They also show that recovery is strongly facilitated by the involvement of peers, friends, and like-minded persons, a community where a person facing mental health problems can turn in order to find understanding and to find support. As the Commissioner for Human Rights of the Council of Europe, I feel, as I already stated, very strongly that human rights must be our guide and compass when imagining the future of mental health services in Europe. They must be the starting point and not an afterthought. There are many human rights at stake here. And let me just mention briefly a few. First, the right to legal capacity means that substitute decision-making is incompatible with the future we are imagining. Those of us with psychosocial disabilities who need decision-making support to access mental health services and to make choices about their healthcare options must receive that support. Second, the right to live independently and to be included in the community must automatically exclude a mindset that conditions to delivery of certain services on the limitation of key life choices. Third, the growing consensus in the international human rights community is that the prohibition of torture and of inhuman or degrading treatment also extends to various forms of coercion that are still, unfortunately, very prevalent in psychiatry, including involuntary placement and involuntary treatment. Fourth, the right to the enjoyment of the highest attainable standard of health must translate into community mental health services that are accessible to all when needed, of appropriate quality, and also affordable. It also means that these systems must pay attention to the essential social determinants of health, notably social protection, living conditions, working environment, and also education. Finally, and crucially, the right to participation. The right to participation means that persons with lived experience of mental health problems and psychosocial disabilities must not be merely consulted by truly involved in the design, implementation, delivery, and monitoring of community mental health services. These are not new rights, particularly not to you. These are all basic human rights enshrined in international binding legal standards, notably the UN Convention on the Rights of Persons with Disabilities, which practically all European states have signed up to. They constitute an excellent guide and define the outlines within which we can imagine the community mental health services of the future. As Commissioner for Human Rights, I will continue to urge member states to live up to these obligations, while directing them also to the ideas emerging from the valuable discussions like the ones we will have today with very distinguished panelists. Once again, I apologize for these technical problems, and I know that also visually, I'm not sure how you can see me because I'm just using different gadgets than envisaged, but anyway, I think it's important that we also mention that mental health matters, and it will continue to matter. I can assure you that me and my office will continue looking at these issues, raising it, and also working with you and many others that would like to make our societies better and more human rights compliant. Thank you very much.
Thank you, Madam Commissioner, for joining us today, for being so preserved to remain with us and stay with us and talk about these important issues. And also thank you very much for your continuous support of our advocacy efforts against the draft of Oviedo Protocol in the Council of Europe, which is of tremendous importance for Mental Health Europe and our partners. Now we are going back to our panelists and to our panel. So now the next panelist will be Guadalupe Morales from Spain. She is a journalist and the founder of the association Fundación Mundo Bipolar, the only user-led organization in Spain, founded in 2004, whose main objective is to fight against stigma and discrimination under the UNCRPD framework. Guadalupe is also a member of the Lancet Commission on Stigma and Discrimination. We are proud that she is also a member of Human Rights Committee of Mental Health Europe, and she is also a member of the Women's Committee at the European Disability Forum. Guadalupe, welcome. The floor is yours. Guadalupe, you must turn on the microphone.
Sorry, here I am. Well, thank you very much for the invitation. It's an honor to be here, and well, I'll provide my experience basically. So first of all, I want to talk about the pandemic, and I would like to say that during this pandemic, our collective reacted excellently during harsh confinement. We had an intense online network of self-help groups that were infinitely necessary and beneficial. We had experience in being locked up in the past. This is a kind of joke, but it is the truth. However, those who were admitted suffered greatly in addition to having lost their freedom. As always happened, they were completely isolated from the outside and weren't allowed to get out or to receive visitors. They were left uncommunicated for months. They could not use their mobile phones, nor were they provided with a tablet or similar. They lived a double confinement. What was its purpose? Considering that psychiatric units in my country, Spain, are corridors without outdoor space, they have to wear all the same impersonal pajamas and have locked rooms. The situation also on this occasion is worse than that of the prisoners. Digitalization is and has been a matter of utmost importance during this pandemic. The digital devices have marked mental health. Communication with others is vital. For us, loneliness is a risk factor. Telemedicine is a fact, although face-to-face is necessary in mental health. Now I'll start from the beginning. I will tell you about my story. I was a journalist at the news section of an important TV channel. I was very successful. However, they fired me when they learned of my mental health diagnosis. Years later, the same story. I was far from the university where I was a teacher, not because of the symptoms, but because of the word, the label, the diagnosis. Nevermore, I could find a job until 20 years later. So without a job, desperately, my husband and I created a website with a forum online which was very, very successful and had a very intensive activity between 2002 and 2008. In that forum, only people with mental health problems share their lives and help each other via their own personal experience. It became a peer-to-peer self-help group without knowing that this had a name. It helped us very much. Now I'm going to talk a little bit about human rights. Everybody seems to know what human rights are. However, why is it not clear when it comes to human rights perspective in the field of mental health? Where does this consolidated idea arise that we are ill people or that we do not deserve to have the same rights? The approach to mental health must be taken in the first place from the point of view of human rights that we are entitled to, in the first place, as holders of rights and not objects of care. Standard approaches from the medical, even from the psychosocial rehabilitation field, or from the economic perspective are wrong, considering us people in need of care instead of holders of rights. Having a mental health problem is not easy. It's not just a clinical problem. We suffer from stigma and discrimination. Stigma is the mother of discrimination. Let's not forget this. On the other hand, diagnosis represents a problem of such magnitude that it allows injustice and outrages to be committed in its name. Finding a way to transcend the diagnosis will be a significant advance, even accepted that there was a health problem initially. Its harmful consequences should be eliminated as it invades all areas of the life of those who suffer from it. Loss of academic opportunities, employment, and above all, in our capacity as citizens. There's a loss of rights, and even more if you're a woman. I would like to give only one example from a study in El País Vasco in Spain about women with mental health problems and violence. Its conclusions were devastating. 8 out of 10 women with mental illness suffer abuse from their partner. It concludes that one of the causes of their increased vulnerability is the lack of credibility that these women have when they tell you that they suffer from these violent acts. I wish to highlight also that forced sterilization is still a reality in the world and in the European Union too. Spain prohibited this only since last year. The rate of unemployment is the highest among people with all types of disabilities, and that of women with psychosocial disabilities is the worst of all. Now let's jump to peer trainings, in which we are experts. There's a kind of knowledge that only comes from one's own experience. It is the true experiential empirical knowledge, the fruit of suffering and the joy of overcoming it. When combined with an honest and loyal exchange with others like us, who have gone through the same thing, the result is prodigious. Only a person who has been there can fully understand and help us heal. These facts are at the root of peer-to-peer knowledge. In 2008, a friend from that forum and I decided to create a course. We analyzed what helped us most. We realized that most of all, it was learning from experience and sharing it with our peers, peer-to-peer knowledge. This is how we managed to regain a sense of belonging, learn self-management, and also understanding what had happened to us and how to overcome it. We launched a research and peer training project to train people with mental health problems, together with Universidad Autónoma de Madrid. So the project objective was to develop a teaching program organized and developed with our users about the characteristics of the recovery process and the requirements to facilitate it, including the UN Convention for the Rights of Persons with Disability principles. It was targeted to users associations, users, and the need to promote a strong users movement to turn to and become a strong voice at the political level. Then we started the training course as well for our students to give talks, seminars, etc., such as in schools. In the years that followed, some of the students became teachers. Our trained peers were paid and well paid for their involvement in these sessions. The conference talks that took place in schools were really exciting. Students were not used to being face to face with a person who had a mental health problem. Again, I would like to stress that our trained peers were paid and well paid for these sessions. This project is unique. We don't know any other like it. Another focus is to train professionals. We have been doing this for the last 6 years. We coordinate these trainings. We have already taught 25 courses to 112 emergency services in Madrid. We have reached out more than 1,300 health professionals. The evaluation have been excellent. The regional government pays peer experts the same as the other trainers, one psychiatrist and one psychologist. We are 2 peer experts in these trainings. Our project was chosen as a good practice by the European Commission. Since 2018, I have been a partner in a Horizon 2020 research project called Recover E, which purpose is the creation of community mental health teams for home care. It has 4 main objectives: policy, research, health services, and to establish a peer-to-peer capacity building partnership in the community, and a service users empowerment objective to implement recovery-oriented care by recognizing the value of experiential knowledge through including peer experts, I would say peer workers, as members of the community mental health teams. It is taking place in 5 countries of Eastern Europe: Croatia, Montenegro, Romania, North Macedonia, and Bulgaria. I have taught courses in those 5 countries. These trainings are targeted people with lived experience who afterwards became peer workers. And I have also given classes for professional psychiatrists, psychologists, nurses, and social workers. One of my subjects is human rights, discrimination and stigma, or the recovery approach, among others, as well as the UN Convention. As 99% of the time, many students have not heard of it, nor of the Human Rights Agency in their countries. This is the same for peers and for professionals. Peer workers have displayed excellent accomplishment as members of the community mental health teams. Having a salary and mutual respect has changed their lives, except for Romania, where they can't pay patients because they are not allowed to work because of the law. They need an authorization from their GPS and never get it. This is discrimination, clearly. During this pandemic, digitalization made a difference. For example, those countries, such as Romania again, whose peer workers in the project did not have it, could not benefit from my mentoring sessions, nor from the online networking between them. Pity. But the provisional outcomes and results are excellent. This demonstrates the importance of peer workers' involvement and community-based mental health support successfully implemented in these sites. This is the first time a person with a psychosocial disability or mental health problem has participated in an Horizon project, myself. After being fired from the news TV channel and the university because of my diagnosis, as I mentioned, now, after 20 years, I have a job. It is very interesting and challenging to see how the adaptation of professionals to work at the same level as me represents an important cultural change for them. How do I see the connection between peer involvement and community-based mental health support? In 2015, the demand of the United Nations CRPD Committee to the European Union was to integrate people with disabilities in all processes that concern them, including access to financing. That will represent then the true and meaningful participation. I was also involved in the joint action on mental health and well-being, where I represented IMIDS, the European Network of Users and Ex-Users and Survivors of Psychiatry, specifically in the work package towards community-based and socially inclusive mental health care, where I was one of the authors. I emphasize constantly the fact that we should be considered right holders in the first place, rather than objects of care. It is we who are placed in psychiatric wards where our dignity is trampled, where we are given a rope and left in a corridor without being able to even enter our rooms. Places where they tie us down or give us an injection, isolate us, infantilize us, deprive us of freedom and contact with the outside world, almost always in worse conditions than prisoners. Places where the staff is missing, often suffering burnout. This is still happening throughout Europe today. I firmly defended that coercion is not care. We worked in this EU program for 3 years, 2013 to 2016. But I can't see a real change in the European Union yet. Still, many people with psychosocial disability continue to stay isolated, fearing themselves and not really realizing the power hidden in their experience, and also not realizing their rights. We strongly believe that peer-to-peer self-help groups, trainings, and organization of people with lived experience, organization with peer experience, this is a clue, can help many of these people find their place and balance in life. But unfortunately, too much attention is still being paid to biochemical solutions and too little to user-led initiative. I and my colleagues throughout Europe hope very much that this approach will change very soon, and our opinion and input sought as mine has been today. Thank you very much for your attention.
Thank you, Guadalupe, for this presentation and sharing with us how serious human rights violations happen in mental health care settings, and how important is it to have users and survivors of psychiatry involved in development and implementation of mental health policies and service provision too. Our third panelist for today is Fiona Coyle from Ireland. Fiona is CEO of Mental Health Reform, which is Ireland's leading national coalition on mental health. She has a profound experience in working with ground projects, community organizations, government bodies, and international NGOs in practitioner and senior management roles, and is involved in driving and overseeing the implementation of Irish Department of Health Policy, sharing the vision, a mental health policy for everyone. Thank you, Fiona, for accepting the invitation to join in this panel on such a short notice. The floor is yours.
Thank you so much. It's a pleasure to be here. So I'm going to share my screen. So bear with me 1 minute. You can see it? Yeah. I hope you can see my screen now. But yeah, thank you for the introduction. So I see there is a few people from Ireland on the chat, so I'm sure they will contribute in the chat some thoughts as we go along. But we're going to talk about the Irish context in relation to the theme that we're speaking about today. So very briefly around mental health reform, we're a coalition, so we're very similar to Mental Health Europe, but at a national level. So we represent over 75 organizations. Here are some of the logos. And what we do is we provide a space for members to come together and to advocate to the Irish government and other stakeholders on the need to reform Ireland's mental health policies, laws, funding and approach. Our focus and our vision is in Ireland where everyone, no matter where they live or who they are, gets support that they need in their own community at the right time. And we really believe that, you know, our services and supports need to be, you know, recovery focused and very much aligned with international human rights principles and practices. Here are social media handles if you want to follow us. So Ireland, I thought just to set the context a little bit, to talk about Ireland's journey with kind of mental health policy reform. So in 1958, 0.7% of the Irish populations were institutionalized in psychiatric hospitals. That's quite a high number. In fact, the WHO in 1961 declared that Ireland had the highest level of institutionalization of anywhere in the world at that time. So that's not that long ago. And what we've seen through the 1960s, 1970s, we've seen the numbers in the institutions move down, which was positive. But developing community-based supports only really started in the mid-1980s with the launch of a report, Planning for the Future. And I suppose the real step change in terms of the kind of government approach policy-wise anyway came in 2006 with the launch of Ireland's landmark policy at the time, Vision for Change. So this policy, it did have a 10-year lifespan. It was 2006 to 2016. And if I can draw your attention to the butterfly symbol that came with it. And the butterfly was quite important at the time because it was seen as a brave and kind of visionary symbol for the significant structural and cultural change that was required to modernize the mental health services and supports in Ireland. The policy itself very much recognized the community as a valuable resource in dealing with mental health difficulties. And it was really a step change, a move away from the institutional-based model towards community-based arrangements. and it moved to involve multiple domains like the need for housing, social services, education, employment, especially with people with complex mental health difficulties. It also introduced community-based mental health teams, and this was an integrated care approach, so that there was kind of teams provided to service users in the context of their local communities, and that it's delivered primarily through these teams, each of which were to cater to typically a population of 50,000 or somewhere around that. Now, the teams were made up of psychiatry, nursing, social work, clinical psychology, and occupational therapy. And very interesting, in the policy, it set out staffing levels for these teams. The policy itself was very welcomed at the time. Now, in hindsight, was definitely not perfect and lots that needed to be improved upon, but it was, you know, recovery orientated, envisaged service users and carer involvement at all levels. It had really kind of a respect for human rights was very much at the centre. And I suppose one of the things that came up in the chat that I want to really briefly reference was it really envisaged a shift, a cultural shift. And there was concerns, and there still continues to be concerns around moving the institutions to the community. So, you know, the shift in behavior that was needed wasn't just alone in the services that were being provided, but in the culture of the delivery to the service and how the service user was treated. But in saying that, something happened. So 2006, new policy, widely welcomed. Then in 2008, the crash, economic crash happened. And Ireland in particular, if many will remember, were one of those countries that was really severely impacted by the economic recession. So we found ourselves in a situation where, as a country, we had committed to reorientating our services from institution-based to community-based services. But we were doing that with dwindling resources year on year and becoming a worse and worse financial situation. So, you know, I think that is worth noting, but it's also very important to note, I believe personally, that during that time, you know, 2006, 2007, Ireland also launched a national cancer strategy. And that cancer strategy, reflecting back, vast majority of it was delivered in the time frame. So while acknowledging that, you know, financial situations that countries find themselves in do maybe prohibit full implementation of policy, the political prioritization and that political leadership is also really, really important. So Vision for Change, while it really was ambitious in nature, it didn't quite deliver the change that many hoped. And it led, I suppose, to a situation where we have in Ireland and have currently, you know, a very patchy approach. It's kind of a postcode lottery where there are good examples dotted around the country, but it very much depends on where you live and what services you have access to. And what's really important, I think, for us in mental health reform is to hear the voices and experiences of those who are going through the services. And that's why in 2019, we published a really important report series called My Voice Matters. And this was the first of its kind in Ireland. And indeed, I think it might be the first of its kind across Europe. But we surveyed 1,200 service users and 800 family members to hear directly from them about their experience of the Irish mental health services. And, you know, I could spend the next half an hour going through, and I will share these reports, but just to give you a snapshot of how people felt. And none of this, I think, will come as any surprise listening to the previous conversation. So 60% of people reported a high focus on medication as part of their treatment and care. 2/3 of people reported that they did not have written recovery plans developed within their community mental health teams. This is despite recovery plans being national policy for over 13 years. There was a lack of discussion among recovery and how mental health difficulties affect other areas of a person's life. There was a lack of referrals noted. There was no information given to people on housing and employment outcomes. And overall, I think the main messages was people did not feel listened to, and people did not feel that they felt that there was a lack of choice in the Irish mental health services, especially in relation to the choice of therapies available to them. So this is a really interesting report, and I will share the links to those that are interested. But that brings us, I suppose, to the kind of 2020, 2021. And one of the things that happened last year, apart from kind of the global pandemic, is that Ireland welcomed a new mental health policy, this time called Sharing the Vision, a mental health policy for everyone. The policy developed, you can see some of the processes outlined. I won't go into them in detail due to timing, but it was over nearly a 3-year process, which involved various kind of reports, engagements with service users, engagement, kind of stakeholder consultations. There was a reference group set up. And this policy, I suppose, is to be broadly welcomed. It is, in terms of how it's set up, it has kind of a greater emphasis on mental health promotion, prevention factors, protective factors, early intervention. And it also has a greater focus on social inclusion and particularly in the needs of particular groups of people within the Irish context. So that is very much to be welcomed because it was very much lacking. The principles of the new policy are welcomed as well. They're very much recovery, they're trauma-informed, human rights, and value in learning are the 4 principles. It addresses the needs of the population. You can see here it's through population-based planning, which is recognised now, I believe, by WHO and others as being kind of a promising practice, a way to approach kind of policy and service delivery. It very much focuses on intervening at the earliest possible moment, and it also focuses on that service providers should very much work in partnership with service users and their families to facilitate recovery and the reintegration through the provision of accessible, comprehensive, community-based mental health services. So just to go back, you can see these are kind of the 4 core domains which are supported through actions and then outcomes. So one of the things that's to be welcomed in this new policy is the fact that there are kind of very detailed action plan at the end of the document that outlines what needs to be done, by who and by when. So that's really to be welcomed as well. And this is kind of, I suppose, the kind of final thing I wanted to highlight is that it is a stepped care approach. So it has 4 tiers. So tier 1, very much kind of social support, peer support, intervention where focus is not maybe a specialist healthcare. Then we have tier 2, which are our primary mental health services. So these are kind of social prescribing, primary care teams, community pharmacies. Then tier 3 are the community mental health teams. What is to be welcomed in the new policy is that the remit of the community health care teams have been expanded to recognise, I suppose, developments over the last decade and the emphasis on achieving recovery-orientated outcomes. So additional I suppose, needs have been identified for these teams, including peer support workers, dietitians, outreach workers, job coaches. So it's very much envisaged to expand the community mental health teams to take on board these additional remits. Promising approaches. I suppose one of the things that was mentioned in terms of the implementation is that mental health reform has been asked to sit on the National Implementation and Monitoring Committee for the new policy. So one of the weaknesses of the implementation of the previous policy was on the implementation and a lack of, you know, a detailed implementation plan and a kind of a group to drive the implementation. So this group was established and we met for the first time last December, and it's very much the initial period is focusing on how it will work. So there's no conclusion to those discussions as of yet, but it's been very clear point that I and others have been making is around the role of people with lived experience, and that we need to find a way of bringing those voices to the core. So we're always very interested in hearing examples across Europe on how we can do that. The principles, I believe, are very much to be welcomed. The community-based approach is very much at the heart of the new policy. The continuation of the community mental health teams and, you know, the inclusion of the peer support workers. I think that recognition of the role of peer workers, and we're moving to really recognizing on equal par that lived experience and how important that lived experience is and how equal it is to all the other disciplines that are involved in mental health services and supports. The policy also outlines kind of the importance for peer-led and peer-run projects in the community, and it does give a commitment to upskilling and investing in these. There's also some really interesting approaches that are being piloted in Ireland, such as social prescribing, which is mentioned in the new policy. But looking forward, you know, what have we learned in Ireland? We in Ireland have had, I think, really good policies on paper for the last probably decade and more since Vision for Change. But we haven't seen, as our report has shown, My Voice Matters, we haven't seen a real concrete transformational change that has been envisaged in these policies. And I think it's really important to remind ourselves of this kind of iceberg of change that I'm sure many of us have seen. And above water, on the tip of that iceberg, there are things, you know, like funding, like having strong policy, like legislative change, like staffing, those things that are kind of so much the focus of many conversations. Certainly in Ireland, we haven't got this bit right yet. Our funding is at 5%, 5.1% of overall health spending. We know WHO recommends 12%. Our Mental Health Act is still out of line with international human rights standards. So we've much to do, but so much has to change on the stuff that's invisible. And I see so much of this coming up in the conversation in the chat today. The values, the beliefs, the attitudes, the stigma. We have so much work to do on the cultural challenges. So you can have really brilliant policy that can say all the right things, but unless we invest and we focus on changing cultures and behaviors, then service users and families, carers, friends and supporters will never truly have the type of services that they are entitled to and that they deserve. So it's really important going forward that we're very much focused on both the above and the below. And strong policy, again, maybe to finish, it's not enough. You know, we need to make mental health a priority. We need to invest both in resources, but we also need an investment in leadership. You know, in Ireland, we've seen that our journey, we've not lacked policy, but perhaps what we need now in what we've been calling for in mental health reform, we need leadership to drive forward those types of really difficult changes, which is, you know, changing mindsets, changing cultures, making really innovative changes to the way that we engage our service users and family supporters, carers and friends. So I think as we look to the future and we see more and more countries develop really progressive policies, we need to remind ourselves that policy change, system change does not end with policy. We need to look beyond that. Yeah, that's me. Any questions, I'm happy to take them, but thank you very much for allowing me to share some of the experience from Ireland here today.
Thank you, Fiona, for representing these developments in Ireland on the national level. It is always important to see the comparative examples, and especially when some good changes happen, so that other countries can learn from them. We all, at the end, need a vision for change, and thank you for providing us with one example how we can do it. So we have some time for the questions from the audience now, and I will start with the question from the audience from Mary Nettle, who commented on the speech from the commissioner by saying, I quote, "I follow Stephanie in saying that people with lived experience really appreciate what you do, the battles you have had and those to come," end of quote. Although the question was for the commissioner, I find it appropriate to put it to all panelists. So the question is, the Oviedo Protocol from the Council of Europe shows how we, people with lived experience, are considered to be risky, and the general public should be pleased that we are offered protection. How do we change these attitudes? So if you could provide a few quick answers. Thank you. Who is going to be first? Fiona, perhaps you are still there with us and others must join. Michelle, also I see you as well.
I'm just trying to look at the written question because I didn't get it all. I mean, please, how do we change these attitudes? You know, I mean, you know, attitudinal change, mindset change is absolutely fundamental to any change in the system. And we heard Fiona and her presentation really emphasize that you can have policy, you can have, you know, change from institutions to community-based mental health services, but you, in the end, if you don't have the real mindset change and attitude change, you can just be replicating the previous system. And I've seen that also happen with new laws being established, new words, but the same old concepts are being perpetuated. So what do we need to do for attitudinal change? We need the right type of programs, training programs. I think we have developed that with our QualityRights training programs. They're able to really reach people at an emotional level so they can connect with what's happening in the mental health field, what's happening to people, and have them understand at a very deep level what needs to change. That's the success that we're having with that training program. So we need to make sure that we get that training program reaching as many different stakeholder groups in as many different countries as possible. We are making it available to all countries in August. So it's up to everyone as advocates to implement a sort of dissemination strategy to make sure it gets everywhere. Just a couple of more quick comments on that. We need to reach the right stakeholder groups, but it's not sufficient just to reach the sort of influencers, so to say. You've got to be very targeted in your strategy to get that mindset shift, but you also need to reach large numbers of people. You know, you've got to really get this sort of societal level change, which means reaching thousands and thousands of people in different countries in order to get the sustainable change. We can't just focus on small groups of people. I'll stop there. Thanks.
Fiona?
Yes, yeah, just to echo what Michelle has said, like, I think, you know, the recognition of some of the principles that may become, you know, we all on this call, I'm sure we're familiar with the principle of recovery, and we're familiar with the principles of human rights in a mental health context, but many aren't. And some of the work that we find, especially when we're working with elected representatives and other kind of key stakeholders, is that real need to acknowledge where we're come from and acknowledge, you know, what people's perceptions and misconceptions are, and to start a conversation from there. So to really kind of acknowledge that not everyone may be aware of, you know, what do we mean. And I think the more spaces that we provide for service users in particular to make their voices strong and heard is really important, and that's something that we very much advocate for. And that's one of the reasons why we did our survey back in 2018, 2019, because there hadn't been any previous effort to really garner the views of those who have been in a very in-depth manner. There had been some other smaller studies done, and the views of those who are accessing the services and how they, you know, how the services were changing or not changing, or assisting or not assisting their recovery.
Thank you, Fiona. And Guadalupe, what are your thoughts? What can be changed and how can be changed so that these attitudes are not prevailing anymore? You must turn on your microphone.
In my opinion, we are in a very good situation right now regarding the WHO and regarding the European Union. And now, in my view, we have to give another step, and this concrete step is to reinforce the users' movement, the users' organization. We are the ones who must lead this. Imagine a blonde, white, blue-eyed man being the leader of the civil rights movement in the 60s. That's ridiculous. But we don't want to be ambassadors and things like that. We need support. We need funding. Infrastructure is so difficult to have access to funding. And that's my opinion. We have to have a little bit more power. We don't have power. Normally, this movement starts from the bottom up, but we have been trying that with all our strength, all our patience, a lot of work, and it's really exhausting. We do that for nothing, just because we believe in that. We are very passionate. But now that we have such a good superstructure like WHO, which I am so happy to hear you, to Mikel, and the European Union, I think it's about time. It's very strange that I am the only person with a mental health problem or psychosocial disability or whatever you want to call us to be part of an important project. That's very strange. It doesn't happen in other areas. So that's my point. We need to be stronger and we need help for that.
Thank you, Guadalupe. And now I'm having a question for Fiona. With your work at mental health reform, what can other stakeholders in Europe, for example, ministers of health, learn from the sharing the vision policy with regards to the community mental health services?
Yeah, like I suppose our policy is very new, so it was only formally launched last year. So we're very much on a learning curve ourselves. But as I kind of outlined in the presentation, I think as a policy, there's much to be welcomed in there in terms of, you know, the embedding of the recovery, the human rights, the trauma-informed approach, how all of this will look like in implementation. I think it's still quite unknown. There's really good work happening, but we need to kind of step up and, you know, transform the services going forward. But I do think there's a role, you know, certainly kind of with other areas of policy, like our mental health commissioner here recently did an opinion piece, and one of the lines in it that struck me was like, we wouldn't, in Ireland, we would be writing letters and complaining on the radio if there was waits for driver's licenses or passports, but it's okay for people to wait 1 year for, you know, a primary psychology appointment. You know, I think it's really important that we make our voices heard, and across Europe that we come together in solidarity to say, you know, we won't stand for this any longer. You know, we want parity of esteem for mental health, and we want the, you know, the voices of those who are using the services to come to the fore. But so a lot to kind of, I suppose, in terms of a policy, but we'd be interested in learning from others as well in terms of kind of examples or promising practices of successful implementation.
Thank you. Now I have a question to Michelle. Michelle, sometimes we hear that we should be cautious about good practices because the definition of what is good can vary from, for example, across a region or depending on the service user. How do you think can human rights help shape the definition of what makes a good practice?
Well, yeah, I mean, I agree. And thank you very much for that question. In terms of the good practices we are showcasing in our guidance, June 10, 3 to 4:45, we used CRPD criteria to define what is a good practice. Mm-hmm. So it means non-coercive practices. It means respect for legal capacity. It means community inclusion. It means participation. And also, in addition to those CRPD criteria, we also included the recovery approach, which in a sense embodies that. But these criteria, these are the criteria which we use to determine what is a good practice and what is not. And so our good practices are embedded in the International Human Rights Framework. Having said that, they're not perfect and we need to strive for perfection going on, but they're pretty good examples of what can be achieved. And as I said, under very difficult circumstances when policy and law are actually not at all aligned with the CRPD. So they're going against the forces in the country, which, you know, is, as everyone probably on this call knows, is extremely difficult to do. So.
Yes, thank you. I think that your future work with the guidelines and with education at the national levels will be very difficult indeed because of these policies and laws. But still, there is something really positive that you are doing, and I think that you could help very much advocates around Europe to pursue the changes in the respective laws and policies. So this is a very big thumb for your work. And now my last question, and I'm sorry, I'm having problems with my mic. My last question goes to Guadalupe, your project on peer support has a European dimension. What are the positive elements and maybe sometimes challenging elements of working on an European level?
Well, as I said, it requires an adaptation, especially from the rest, because we are used to have projects, to lead projects, small projects, and coordinate them. So it needs a change of culture. That it happened little by little, but at the beginning it's kind of difficult for the rest. But right now I can say that everything is on place. That's for one hand. The other thing is that human rights have to be ingrained. Everything has to be related to human rights. And still the biomedical model is too much established, and that's a little bit difficult. And it had worked very well, relationship between the community mental health teams and what they call the patients, people that are suffering crisis or are not feeling well or things like that. That has improved a lot. And besides, this project tries to demonstrate after they do all the evaluations and things that this can be implemented in other countries in Europe. Besides, it seems that it's less expensive than other systems. So, in my opinion, it has been and is a wonderful experience for me, and I believe that for the rest.
Thank you. Thank you very much, all of you, for today, for your wonderful presentations, and you gave us the new hopes, the new visions, something new to go on. And now I give back floor to Ljuska for concluding remarks.
Thank you, Christian. Well, I would like first to thank all of the speakers of today and you, Christian, for facilitating the panel discussion. Big thanks also to all the participants. You've been so active. The chat has been exploding, so it's been really wonderful to see all of the exchanges. I would also like to thank the team, my colleagues who, in my not very objective opinion, did great work of organizing this very inspirational event. Before I actually close, I would like to remind that the WHO guide will be launched officially on the 10th of June. I would like to draw your attention to an interesting event organized by the Office of the High Commissioner for Human Rights Europe on the 18th of May. It regards human rights and mental health during and after COVID-19. And I invite you again to contribute to our European Mental Health Week. There are plenty of activities, events in Instagram, Twitter, so be active and spread the word. And now my concluding points. Well, it's been difficult. What I've done, I've written down the words that were coming up more often. And so what I've done is transform, change, and shift. So I think there is a big consensus about the need for a significant change, and this change needs to be long-term and sustainable. And we have a lot of evidence that supports the need for that change. On one hand, we have the evidence of the many violations of human rights in institutions. And on the other, we have evidence of very good practices for community-based services and other alternative services. So we need to use this evidence to raise awareness, and this evidence needs now to feed into policy. But we've also heard that good policies and practices are not enough. We need a strong and knowledgeable and committed leadership. And that is still not enough. There is a big need to also change cultures. So we need much more work in changing minds, values, attitudes, and behavior so that we can really put an end to stigma. Stigma and discrimination were the other words that kept coming up. The other one was power. So we also need to shift back the power to people with lived experience of mental health issues. And we've heard many ways on how we can do that. We can do that by really having them participate in everything that counts. We can empower them. We can provide peer support, and we can strengthen and build users' movements. And I'd like to conclude with one statement, which is people and human rights have to be the starting point. Actually, I'd like to close with not something I've heard, but something I've felt throughout this event. I felt a lot of passion, commitment, strength, and power. And that gives me a lot of hope and optimism in believing that we can achieve this change. And as Fiona said, we can do that by really joining forces and supporting each other. So I thank you again very much, and please enjoy the rest of your day. Goodbye.
Thank you. Thank you very much.